Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome to episode 2 of the Talking MAS, a CME case-based podcast series. I'm Dr. Alexei Grom, and I'm joined by Dr. Scott Canna. In this final episode, we provide expert interpretation of clinical data for current treatment options for macrophage activation syndrome. Case presentations are discussed to help clinicians with diagnostic approaches and selection of appropriate treatments. It is important for clinicians to recognize the varied presentations of MAS, as well as their implications for clinical management, and these will be discussed within the case presentations.
So with that, I think we'll enter in to some cases, and I'll present the first one, and at a couple points in this, we will have some breaks for some audience participation questions. So the first case is this 5-month-old girl with known trisomy 21. This young lady is a patient I saw a few years ago. She was doing quite well following a repair of a heart defect and a pyloric stenosis when she presented with what appeared to be, a severe viralish syndrome with inflammation and high fevers. But the persistence of those fevers and the persistence of high biomarkers like CRP brought her into the hospital, where she had the rash that you can see pictured, which was sort of a mostly macular, somewhat evanescent looking rash. She had a modest elevation of her liver enzymes and triglycerides. She had evidence of reticuloendothelial activation in the form of big spleen and liver. She did eventually undergo a bone marrow biopsy, which did demonstrate some increased hemophagocytosis, but no evidence of malignancy. Her cell counts were low and somewhat dropping before our eyes, with a low platelet nadir and other evidence of DIC in the form of low fibrinogen. Her peak ferritin in those first couple of days of admission was over 40,000. And importantly, in all of these efforts, including some imaging, there was really no evidence of infection or malignancy that was driving all of this. So, she has all of these features that we associate with this HLH-MAS state. We eventually received results from some of our fancy laboratory tests or specialized testing. So her soluble IL-2 receptor was about 8,000, which is certainly not the highest we've seen, but quite impressive. But her IL-18 levels were, in the range that we associate with macrophage activation syndrome. In this case, over 250,000 picograms per ml. Her NK cytotoxic function, as often is the case in these acute scenarios, was not able to be performed due to just an incredibly low number of peripheral NK cells. But in a little bit after that, when her NK numbers had improved, her granule mobilization, as assessed by CD107A, was found to be normal. Her cytotoxic cell expression of perforin granzyme was normal. And eventually genetics returned this result that she had a heterozygous but known pathogenic variant in the gene encoding perforin. And this is the flow cytometry of her perforin here, where her perforin expression is overall about at the normal range, yet she has this heterozygous defect. So this heterozygous defect harkened back to exactly what Dr. Grom was mentioning before, that we've got these familial HLH causes of a hyperinflammatory syndrome, and is that really what's driving this patient's disease? The reality is that lots of us listening on the podcast tonight may be harboring heterozygous variants in some of these genes. They're certainly common in large population databases. And so the extent to which that was contributing in this patient remained sort of tantalizingly unclear. So she checks all the boxes in terms of criteria for HLH. Dr. Grom mentioned this IL-18 as a diagnostic and monitoring marker for HLH-MAS. This is a adapted figure from a meta-analysis. So often has IL-18 been measured in systemic J still disease and MAS that there was a meta-analysis showing a pretty profound specificity. In fact, I can think of no other inflammatory biomarker that has diagnostic specificity, anything like IL-18 does, when you're talking about levels in the range of 40,000 picograms per ml or above. In this case, this patient had an IL-18 level of 260,000, so easily within that range. It may be the kind of thing that predicts the development of MAS in systemic JA patients. It certainly suggests the more systemic flavor of systemic JIA. So much like the majority of our voters, this patient did receive anakinra, but she also received the HLH94 protocol, including etoposide and dexamethasone. And her response was quite good. Her ferritin levels normalized, cell counts normalized. The increased risk of marrow failure and secondary malignancy in trisomy 21, coupled with her response, we deferred transplant. She was able to wean off steroids, and we were all congratulating ourselves for a job well done when she came back just a few weeks after. I think this is just a summary of at the end of that initial period, her improvement of platelets. Her IL-18 level dropped all the way down to about 1,000. Still not the normal range, but quite close and fairly reassuring. But as I mentioned, just a few weeks after we stopped steroids, she returned again with some low-grade fevers and rash. We were hopeful this was just a little intercurrent virus. But to ward off evil spirits, we started a relatively low dose of methylprednisone, rechecked her IL-18, which had rebounded back up into a pretty high range. And again, she sort of decompensated before our eyes. And before we knew it, we found that she was detectable adenovirus in her blood. And so here's the progression of some of those labs. As things sort of wound on, her ferritin didn't go back up into the 25 to 40,000 range, but rising above that threshold that we call MAS, re-elevation of her C-reactive protein. Again, we see this sort of blossoming of her CXCL9 and a rising IL-18 levels, and bumping of her soluble IL-2 receptor back up to where it had been during MAS before, again, as an indication of this T-cell activation. So obviously, this is a series of lines that are almost unintelligible, but this is her course over time. We debated mightily about whether this young lady had earned herself a transplant and the degree to which that heterozygous cytotoxic impairment was interacting with IL-18 or adenovirus or all of the above. So she was treated again initially with anakinra and steroids, a somewhat lackluster response, and so was initiated on imapalumab. And of course, in addition, trying to treat some of her triggers, including brincidofovir. I believe she did get a few doses of etoposide, but we weren't really sort of committed to that course. And over time, she did respond. It took an incredibly long time for her to clear her adenovirus. She had a small bump in asymptomatic transaminitis a few months later. We actually had her visit our colleagues in Cincinnati to sort of get their opinion on whether she should go to transplant as well. And they agreed with us that, especially in this context, transplant would be incredibly risky for her. And she had always been reasonably responsive to medical therapy. And so, I treated her for weeks and weeks as a ticking time bomb. Like I said, it took almost 4 months for her to clear her adenoviremia. But her labs did quite well. We were able to get her off of imapalumab and eventually off of steroids as well. And I kept her on tofacitinib monotherapy. This is before we were using more of some of the other, maybe more specific JAK inhibitors, for weeks, in large part because their soluble IL-2 receptor never quite normalized. And so, that last data point out here at day over 1,500 is to reflect that, sure enough, she seems to have weathered the storm for another couple of years. Her IL-18 is now down into the normal range. So key takeaways. multiple contributors. Just because a patient has high IL-18 doesn't mean they can't have other contributors. Trisomy 21 itself has certainly been associated with more severe systemic JIA instills and some MAS. We were, it was important to treat both the HLH MAS inflammation initially with low-risk interventions like anakinra, and then moving to steroids and eventually imapalumab, but also contributors like this T-cell hyperactivation and adenoviremia. In a patient like this, protocol-based treatment is often just not possible. And we really benefited from a multidisciplinary, iterative approach. We were really careful about trending disease activity markers and specific inflammatory biomarkers, and her soluble IL-2 receptor was enzymatic. And that the decision for transplant is always a challenging one, and particularly in patients like this. And we were glad to have, again, our multidisciplinary approach, as well as another set of eyes from another great group. So I will shift gladly over to Dr. Grom, who's going to tell us about a slightly older patient.
Thank you, Scott. That was very interesting. My patient is somewhat less complicated, but still, I think, interesting. He's a 20-year-old male with adult onset Still's disease that was initially diagnosed at the age of 16 years, based on a very characteristic rash, very characteristic fever pattern, as well as inflammatory polyarthropathy. His disease was remarkably responsive to IL-1 inhibiting agents and had been controlled very well with monotherapy with canakinumab. Then he presented to our emergency room with a 3-day history of high persistent fever, severe fatigue, increasing joint pain, as well as petechial rash. The exam in the emergency room was also remarkable for mild hepatosplenomegaly and impressive cervical lymphadenopathy. He did not have arthritis at that time. The laboratory tests that were obtained in the emergency room are shown on the right side of this slide. These patients did have significant cytopenias affecting actually at least 3 cell lines. He had low neutrophil count, low lymphocyte count, low hemoglobin, as well as low platelets. His inflammatory markers were high. CRP was highly elevated. Paradoxically, his erythrocyte sedimentation rate was only 7 millimeters per hour. He did have evidence of coagulopathy. He had very high levels of D-dimers and low levels of fibrinogen. And most impressively, his ferritin level was at 6,000 micrograms per liter. The additional laboratory tests that we obtained in the emergency room included quantitative PCR for EBV and CMV, as well as serum levels of CXCL9, IL-18, and soluble IL-2 receptor alpha chains. But it looks like the majority feels that the most likely diagnosis here is macrophage activation syndrome, and we certainly did agree with that. Dr. Canna just discussed a general approach to patients with hyperinflammation and macrophage activation syndrome. So based on these recommendations, we decided to proceed with corticosteroid therapy. So he was started on high-dose intravenous methylprednisolone pulses at 100 milligrams per day for 3 consecutive days. And with this treatment, he did stabilize clinically. We did observe a mild improvement in the severity of neutropenia, lymphopenia, thrombocytopenia, as well as we observed stabilization of his serum levels of fibrinogen. But at the same time, we received additional laboratory test results, and his quantitative PCR for EBV revealed 500,000 copies per ml. He also had strikingly high levels of CXCL9 at 34,000 picograms per ml, which is certainly reflective of extremely high interferon gamma activity. His IL-18 level, total IL-18 level, was at 104 1,000, and he also had markedly increased levels of soluble IL-2 receptors. So we certainly felt that it was most likely it was an EBV-induced macrophage activation syndrome. However, when we switched from IV steroid pulses to more conventional doses of corticosteroids, still IV, we certainly saw a massive rebound of cytopenias. That was very concerning to us. We actually did perform a PET scan that showed markedly increased uptake in the spleen and for some reason in the axial skeleton. So certainly we were wondering whether we might be dealing with some kind of EBV-induced lymphoproliferative disorder. So for that reason, we did proceed with a bone marrow biopsy that did not reveal overt evidence of leukemia or lymphoma. But we did see increased numbers of cytotoxic CD8 cells, as well as a massive expansion of CD163 positive histiocytes, as well as scattered hemophagocytosis. So although this biopsy was performed while the patient was on steroid, we felt that the most likely diagnosis in this case was in fact macrophage activation syndrome in a patient with adult onset still's disease triggered by EBV infection. The other thing I would like to stress is that the levels of CXCL9 were high at the very beginning, and they remained very high by day 4. And for that reason, as the next step in the treatment, so our initial thinking was exactly the same. We were debating between rituximab and emapalumab. So let's just briefly review potential therapeutic targets in this particular patient. So certainly we could target the expansion of cytotoxic CD8 cells with cyclosporine. I think it's a very reasonable option. We certainly could consider anakinra that should provide a better control of the hyperinflammation of the underlying disease, although at that stage we did not feel that his adult onset still's disease was actually active. Other options included JAK inhibitors that would target interferon-induced signaling pathways, as well as signaling pathways triggered by some other cytokines involved in MAS. And I absolutely agree with those who chose rituximab. We do believe that in this particular clinical scenario, this uncontrolled expansion, persistent expansion of cytolytic CD8 positive T cells actually is driven by the viral infection itself. It's driven by the virus that is harbored by B cells. And certainly rituximab that would eliminate these B cells has been successfully used by many physicians in a similar clinical setting. We felt that this patient was not improving at all, despite massive doses of steroids. In fact, some of the laboratory features were worsening, and we felt that we should choose an intervention that would be very, very quick. And we felt that emapalumab would provide a quick neutralization of interferon gamma and a quick reversal of the clinical picture of macrophage activation syndrome. So here I'm showing the laboratory results just prior to the initiation of emapalumab. The patient was anemic. The platelets were very low at 93,000. He had very high level of serum ferritin at almost 12,000. His fibrinogen was trending down, and he had significant liver enzyme abnormalities. So he received the first dose of emapalumab at the dose of 6 milligrams per kilo, and he markedly improved 24 hours later. So if you look again at the right side of the slide, if you look at the numbers on day 6, this is about 24 hours after the first infusion of emapalumab. The numbers were certainly still abnormal, but every single parameter was moving in the right direction. And you see a dramatic improvement in the laboratory parameters by day 7. which was about 48 hours after the first infusion of emapalumab. And we were chiefly impressed with the fact that despite the treatment with Gamifant, these patients cleared EBV infection very quickly. Within 1 week, the number of viral copies reduced from almost 500,000 to just 3,000. This aspect actually of the disease presentation did worry us initially, but again, we were very pleased to see that emapalumab did not affect the ability to clear the virus. So the question was, what should we do next? Do we continue the treatment with emapalumab? The CXCL9 level at that stage was still mildly elevated, suggesting that we did not fully neutralize interferon gamma activity. So we decided to proceed with 2 additional doses of emapalumab at 3 milligrams per kilo on days 8 and 12. And by day 12, the CXCL9 levels completely normalized, suggesting that we fully neutralized interferon gamma. We observed an almost complete resolution of neutropenia, lymphopenia, thrombocytopenia, and hyperfibrinogenemia. The ferritin level remained mildly elevated at 1,023 micrograms per liter. But even this particular laboratory parameter was moving in the right direction. He was discharged on day 13 on oral prednisone at 60 milligrams per day, and we restarted canakinumab. We gradually tapered prednisone over the next 2 weeks, and he remained on a canakinumab monotherapy and currently is doing well. So the lessons learned from this particular case is that if macrophage activation syndrome, if triggered by infection, and if the infection remains active, immunosuppression plus treatment of infection is still necessary to control this exaggerated immune response. In this particular case, we were concerned for about the possibility of some kind of a lymphoproliferative disease. And for that reason, we worked very closely with our hematology oncology team. And I think a multidisciplinary involvement is very, very critical in this type of patients. And the final conclusion is that the use of emapalumab for severe MAS in these patients was very effective and safe, even in the setting of ongoing infection. And thank you. I think this was my last slide.
All right. I think that finishes the didactic portion of our evening. We have a number of questions in the chat here. I'll take the first and then I'll throw the second to you. Why is serum ferritin so high? Where does it come from? And later on, there's a question about, do you need a high ferritin to have MAS? Taking the last part first, essentially, yes. In almost every published series, anything that's been considered to be HLH-MAS, a ferritin at least above, 500 or 600, but often into the thousands, has been an incredibly sensitive marker. Certainly, high ferritin is not specific, but if it's normal, I think that in general, we look for other causes of the patient's symptoms. Where is it coming from? It's a tough question. Ferritin is a large macromolecule. In Still's disease, there's good evidence that the ferritin that you're measuring in MAS or hyperferritinemia is a non-glycosylated and maybe more hastily assembled molecule. Its production is also driven not just by inflammation, but by iron. And so I've certainly had patients who seem to be doing pretty stable and got a transfusion for one reason or another, and watched their ferritin level jump, even if I thought their inflammation was relatively stable. But certainly, iron overload is not sufficient to give you a ferritin of 10,000. And in mouse models, there's good data that interferon gamma may be a specific driver of ferritin production by tissue macrophages. So it may have some specificity to HLH-like physiology. So Dr. Grom, sometimes investigations take time. Do you wait? Do you just give IVIG for waiting for results? What do you do about MAS and lupus?
The investigations do take time, but again, it's very critical to reverse this hyperinflammation in these patients. So typically, starting steroids and perhaps anakinra is a relatively safe approach, even the diagnosis may not be fully clear. So we think that some kind of a broad immunosuppression with mainly steroids plus minus anakinra should be considered early before the investigations are completed. MAS in suspected lupus patient, yes, it's a good question. Certainly the diagnosis of MAS in lupus is much more challenging. But in my experience, most of those patients fortunately do respond to corticosteroids, the majority of those patients. So this is something that should address both the underlying disease and macrophage activation syndrome. The question about S100 proteins is a good one. Certainly, we see skyrocketing levels of S100 proteins in patients with MAS, but we certainly see somewhat comparable levels in some patients with underlying active systemic JIA as well. And we don't think that this testing is sensitive, specific enough to distinguish between MAS and the flare, conventional flare of systemic JIA. The question about the cytokine storm in MAS and COVID and MISC in particular, I think it's a good one. When we suspect, for example, systemic juvenile idiopathic arthritis, we typically order ferritin, CXCL9, IL-18, and we think this panel could be very helpful with the diagnosis. And we were developing that panel during the COVID-19 epidemics. We started seeing patients with MISC, and we started using actually this panel for patients with MISC as well. And we actually realized that there were kind of two distinct groups of patients with MISC. One behaved more like Kawasaki disease, and they typically had relatively normal or just mildly elevated levels of CXCL9. And the other group actually had strikingly high levels of CXCL9, and there were some other features suggestive of MAS. So we think that, again, even within MISC, there is heterogeneity with a subgroup of patients that do seem to behave with like patients with MAS and systemic JIA with very high levels of CXCL9, and we do think that group potentially could benefit from emapalumab as well. The another interesting question is high ferritin a must for the diagnosis of macrophage activation syndrome? There are exceptions. I can tell you that the vast majority of patients with MAS have strikingly high levels of MAS. But certainly, I remember a few patients whose level never exceeded 500. So it's certainly very, very reassuring to see high ferritin to diagnose MAS. But certainly there are exceptions. They are rare, but these exceptions do exist, and we need to keep it in mind. And I believe we did address most of the questions, correct?
There's a couple more. One about, what's so special about ehrlichiosis? It's a good question. I mean, it's an intracellular bacterium, and I think that in terms of driving interferon gamma production and Th1 responses, intracellular bacteria and viruses are particularly good at that. And we've certainly had a couple of very challenging cases of ehrlichiosis. It's not the easiest diagnosis to make. The morulae on peripheral smear are not always obvious, and it's quite a slow-growing organism, and so you have to be thinking about it in order to send the PCR test. Doxycycline is certainly the antibiotic of choice, but I think you're getting the recurring theme that management of the cytokine storm, if you will, or hyperinflammation with steroids, IL-1 inhibitors, sometimes Gamifant, is often necessary to prevent organ dysfunction, and we've certainly used it in some of our ehrlichiosis patients. I'd like to take this question about the cytokine panel guiding biologic choices. I think the temptation is certainly that, whichever is highest is the one we should block. And I would say that that's not a great strategy. I think that these cytokine panels first of all, the cytokine panels that most of us send that include things like TNF and IL-6 and IL-8, these are not particularly specific and were not selected for their utility in any of these diseases. And so really it's more patterns of abnormalities that lead you into certain diagnostic categories. Interferon gamma and IL-10 being more indicative of an HLH-like physiology, and maybe just TNF and IL-6 maybe more of a bacterial type infection. Our experience with tocilizumab in cytokine storm is actually somewhat limited, maybe to the COVID-19 patients who are their cytokine levels are much lower than the kind we see in HLH, MAS, and CRS. And we've certainly had patients whose CRPs and sometimes ferritins looked a lot better than the patients did on tocilizumab. And so we tend not to use it quite as much, in part because we think sometimes the biomarkers improve more than the patients do.
So, Scott, the last two questions I probably should address. So the first one is about the need to document hemophagocytosis to diagnose MAS. The answer is absolutely not. The demonstration of hemophagocytosis is not required for the diagnosis of MAS. First of all, it may not be apparent at the early stages. There may be some sampling issues. So the answer is absolutely not. The second question that I would like to address, I think I maybe did not explain it very well. In our patients, we did not use rituximab. We used just emapalumab. And that was what's interesting to us. Even with just emapalumab, the patient cleared the EBV infection very, very quickly. So I don't think I'm brave enough to use these two medications, rituximab and emapalumab, at the same time. And the last question about anifrolumab in MAS, it's a monoclonal antibody that certainly is very similar to emapalumab. I think it has been in some clinical trials in some other inflammatory diseases, but I've never heard of anybody using this particular drug for macrophage activation syndrome. But I would expect that it should be similar to emapalumab.
Is this anifrolumab? I think that the questioner maybe means anifrolumab, which is interferon alpha. It's the interferon alpha beta receptor blocker, and so that's not going to block interferon gamma signaling. And so my use of it, I've actually never used it in lupus, which I think it's approved for. I've used it in some of the type 1 interferonopathies with actually quite good effect, but would not be excited maybe to use it in HLH or MAS. One, because it's not going to block the interferon gamma that we think is somewhat central. And two, if there is an underlying viral infection, I worry a lot more about blocking type 1 interferon, which anifrolumab does, than I do about blocking type 2 interferon, which is interferon gamma, which is less essential for fighting viruses, as Dr. Grom's case illustrated. So I believe with that, we are at time. Certainly been a lively discussion, and I'm grateful for all the questions and for the lively conversation, and hope we can do it again sometime.
Thank you very much for your attention. Thank you for listening to this final episode of Choking Macrophage Activation Syndrome, a CNE case-based podcast series. We hope you enjoyed this podcast as well. Thank you.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.